Thank you, Dr. Pandey sir. Thank you, SPOSI and the Scientific Committee of AIOS for this wonderful session on pediatric ophthalmology and strabismus. I'm Dr. Rishikesh, and the topic of my presentation is management of acute acquired comitant esotropia. I'll start with one case of a 18-year-old female who presented to me with sudden onset inward deviation of eye. Predominantly, it was the right eye and diplopia. It was a binocular diplopia, and the patients suggested that the diplopia was almost same in all positions of gaze. There was not much of a difference. We did a diplopia charting and found that the diplopia was almost the same in all positions, and there was no positive history systemically, no history of trauma or a viral illness. Her visual acuity uncorrected was 6 by 6. Anterior and posterior segments were normal, and she didn't have any refractive error. So, based upon, this is the video of the same patient. You can see that it appears to be a comitant esotropia. There is no limitation of movement, especially in abduction, because sixth nerve pulse is more common when we actually consider a patient with esotropia and diplopia. We did a MRI, which also turned out to be normal, and blood tests, for especially the routine HbCb CSR, was also normal. She was hence diagnosed as a case of acute acquired comitant esotropia, and there was no much change over 3 months of time. So we advised surgery for her, a bimedial recession of 6.5 millimeters. We had a residual of around 5 prism diopters, but that's what we usually aim for in the beginning of esotropia surgery. So coming to esotropia, can be congenital and acquired. Congenital, most common is infantile esotropia, or rarely it can be congenital sixth nerve palsy. Any esotropia which presents after 6 months of age, we consider it as acquired esotropia, which can be comitant or incomitant. Comitant is accommodative, that is related to the refractive errors, or it can be non-comitant, in which includes cyclic esotropia, sensory esotropia, and AACE. Incomitant can be paralytic, which is sixth nerve palsy most commonly, or restrictive, as the list suggests. So coming to acute acquired comitant esotropia, they have been classified into 3 types. Though type 3, that is Belchowski type, is related to high myopia, it is believed to be with fibrosis of the lateral rectus and contracture of the medial rectus. So many of the clinicians, they classify it as a restrictive strabismus and not as a part of AAC. Type 1 is related to history of occlusion, most commonly anisohyperopic amblyopia, but also because of chalazion or removal or foreign body removal. Type 2 is most common, that is Franchetti type. I'll be sharing the clinical features now. So type 1 is related to history of patching, and there is breaking of the fusional amplitudes after disruption of the binocularity. The problem is, once the binocularity is established, the strabismus still remains in many of these cases, and we need to look for a refractive error, treat them accordingly, but many of the cases will need a surgical correction as well. Coming to type 2, which is also called Franchetti type, the patient which I just showed seems to be in that category. It usually presents in first or second decade of life, with sudden onset esotropia with diplopia. The esotropia is a large angle, somewhere between 25 to 50 prism diopters. The neurological examination and neuroimaging is normal in these cases, and many of the clinicians feel that there is no need of doing a neurological examination, but we need to rule it out, especially at some abnormality at the CP angle, before we diagnose it as AACE. Sometimes mild myopia might be associated with these conditions. Just a brief flow chart about how to manage a patient with acute comitant esotropia with diplopia. Rule out that there is history of patching or any positive history. If patching is present, consider it as type 1 and correct the refractive error. And for residual esotropia, the patient will need surgical correction. Coming to if there is no positive history, you do a neuroimaging to rule out any neurological condition. If neuroimaging or MRI is positive, you would take a neurologist opinion, and for the residual squint or alignment, we will need surgical correction. The treatment protocol, there are no clear-cut guidelines as far as AAC is concerned, but we follow the same as for any comitant esotropia. Clinicians have used botulinum toxin for esotropia less than 25 prism diopters in both the medial recti, but anything beyond that will need surgical correction. The surgery of choice is bimedial recession, and usually the alignment results are good. binocularity or binocularity depends upon the age and stage at when you are operating. So either the most commonly done surgery is a bimedial recession. If it is planned earlier with frequent follow-up of the patient, the tone of the muscle is the same as what you get for a normal patient. So there is not much of a contracture or contracture of the medial rectus. Very rarely you might have to do 3 muscle surgery, or if the patient insists on getting operated only one eye, then we might have to do a recess resect or resection of the lateral rectus as well. It can instead of this, plication can also be tried, but I haven't done that so far. So before I close, I just wanted to share one patient. She had appeared to be a case of AACE. The only positive history which she had was a smartphone use of more than 6 hours. I had not presented this case had it been pre-pandemic period, but this is something very important because there are clinicians who have reported even Indian studies suggesting AAC because of excessive gadget use. So usually she needed surgery and the surgical results are good. So to conclude, AAC is an important cause of sudden onset comitant esotropia. Many of the cases need surgery or botulinum toxin can be used. They have good alignment results, and always ask history of excessive gadget use when you are considering AAC. Thank you.
Thank you, Dr. Rishikesh, for a very nice presentation. I think a few things we have to keep in mind. One is that accommodative esotropias can present initially, but the age group is about 1.5 to 2 years, most of the accommodative esotropias. And the AAC age group is usually older, about 7-8 years. And what we have to remember that once in a while you may have serious neurological disease like a tumor or some kind of those conditions one has to keep in mind. So if it is worsening, if there is, and also need to look for maybe some sign like nystagmus or papilledema. So they need to be examined in a bit more detail in a comprehensive way, so that those possibilities are ruled out. Otherwise, of course, neuroimaging has to be done. If it is not getting better by, I think, at least 3 months, you must do a neuroimaging. And of course, good refraction. Anything, Shivangi?
Just one comment I wanted to make is the type 1, type 2, type 3, and normally we classify it like that, but there's a thin line between the types, and sometimes it is better to classify it as small angle less than 20-25 prism diopters and large angle more than 25 prism diopter, which helps us in management also. And yes, but sometimes that may not work. And one suggestion is it's better to keep these patients on adjustable suture, because we need an exact alignment, because they have a very good potential for binocular vision.
And these ones with CNS involvement, they don't have motor potential, they don't fuse because of obviously CNS lesion. So if there is no motor fusion, that is one of the parameters to suspect that there could be CNS involvement. Thank you, Dr. Rishikesh. Anybody would like to say anything from the audience?